Very good. Okay, well, good afternoon, everyone, and welcome to our IHA Professional Development webinar, where we're going to spend the next 60 minutes with our very special guest from Thirrili. I'm going to actually let Tanya introduce herself a little bit later on. But my name is Charlie Giles, and I'm a very proud descendant of the Wanneroo people in the Hunter Valley, New South Wales. And I'm the business manager here at IHA, and it's going to be my absolute honour and pleasure to introduce you to our two very special guests from Thirrili this evening. Of course, before I do that, I would first like to acknowledge the traditional owners of the land in which I'm broadcasting from today, the Ngunnawal people, and thank them for their continued custodianship of this beautiful place that I know and love as Canberra. I'd also like to acknowledge the elders past, present and emerging who may be joining us this afternoon. And of course, all the traditional owners from the countries that you're all zooming in from, and extending my gratitude for the care that they are taking of all of you during these unique times. So now let me introduce to you the fabulous Jacqueline McGowan-Jones, Thirrili CEO, and Rachael Schmerl, the Executive Manager, Programs and Policy. Thank you, ladies. I'm going to hand it over to both of you.
Thanks, Charlie. I'd also like to acknowledge the traditional custodians of the lands and waters on all the countries that we are meeting on today and pay my respects to our elders, past, present, and our young and emerging leaders and elders of the future. I also want to pay my respects to our ancestors and acknowledge that they keep us safe in our daily lives and lead us on a strong path that supports our work, particularly those of us who work with our own peoples. I'm a bit of a mix, really, thanks to the stolen generation. So I'm Warramungu Aranda Wallarong, and then on my mother's side, I'm Prussian Jewish descent. So it's a bit of a mix. And I've been at Thirrili since the 15th of June. Some days it feels like the 15th of June 2015, and other days it feels like it was yesterday. So thanks for having me, and I'll let Rachael introduce herself.
Thank you. I too would like to acknowledge the traditional owners upon the land on which we're all meeting on. I'm currently sitting on Nukunnu country here in South Australia, Port Augusta. Also like to acknowledge the elders, both past, present and emerging. My background is Yankunytjatjara Aranda from my mother's side, and from my father's side is German and Irish background descendants. Thank you.
Thanks, Rach. I'm going to share the screen in a moment, and we're going to hope this all works, everyone. So we'll try not to do death by PowerPoint, and we'll do a presentation, and then at the end we'll have time where we can all ask questions and share. I should have also said I want to pay my respects to the Larrakia peoples. I live in Darwin. I'm blessed to be up here. We're fairly much COVID-free and warm. So I pay my respects to the Larrakia peoples. I'm going to share the screen and see how we go. Okay, goodo. And we'll start at the beginning of this slide presentation. Right, there we go. So you've just met Rachael and I, and this is about the work of Thirrili, and primarily that is about our work with postvention, primarily in suicide postvention, but we also work with families and communities where there have been other traumatic incidents that caused death. So we've already done the acknowledgement, but this is very important to us in our space, that we have a minute's silence right now to remember those who we've lost to suicide. And the real tragedy is that this is children as young as 7, right through all age groups. So if I could ask for people to please observe a minute's silence in memory of our countrymen who have passed. Okay, thank you, everyone. I don't know of a family, an Aboriginal or Torres Strait Islander family, that life hasn't been touched by suicide. All of us who work at Thirrili have lived experience. So for me, my mother took her own life 5 years ago next month, and my cousin sister took her own life nearly 20 years ago, and my daughter niece is making a number of serious attempts on an almost daily basis. Rachael also has lived experience of suicide. That's her story to share, so if she feels like sharing, but Rach, you don't have to. And
Thank you,
it means
Jacqueline.
that our people that work with us have a really good understanding of the impacts of suicide and other death caused by critical incidents. It's really important for us that we remember that this country on this map is a continent, and whilst Australians in the broader terminology call this a country, for us we are a continent with many, many, many different countries, and we have to, as a national service, work with people across those countries. So we're working with Palawa in Tasmania, we're working with Nyunga or Yamaji or Thirrili, which is up here in the northwest of WA. We might be working in Arundurunu, Pitjantjatjara, Yankajara, Ngununjatjara lands, Yaru country, Wiradjuri country, Gubbi Gubbi. So we work right across the country, and to do that we need to make sure that we're employing people who are either connected to those countries, and often that's not possible, or that we have in place a network of supports that supports people in how they engage in those communities and observe those protocols. Protocols are particularly important in some of the more remote localities. It is not appropriate for us, for example, in the Ananu, Pitjantjatjara, Yankajara, Arunda, Ngununjatjara lands area to immediately attend a community post a death, because sorry camp is being established, and there's a very strict protocol for sorry camps, which I'm sure many of you are well aware. But it is a very big space to cover, and it is a challenging environment for us to make sure that we can support our people to support our people. So the webinar today will cover how Thirrili started and how far we've come, and also where we've still got to go. We'll also talk about the processes and practices that support delivery of postvention services to families and communities. Really important to discuss the links between postvention, intervention and prevention, and then we'll get to a question and answer session. So, jumping right in, why do we need to address suicide? Well, obviously preventing suicide is a priority. It is preventable, and we strengthen for our clients access to other supports and provide a model of care that is based on protective and nurturing approach and recovery, and uses trauma-informed practice. And we also work on a through care planning model. Now, through care planning is more widely known in the justice system, but it is an approach that we use because what we are trying to do is build, whilst we also work with individual families, we're trying to build the capability within communities and families to be able to support each other at a time of their grief, loss and trauma. People talk all the time about capacity building in our communities, and I actually hate that language. I like to use, and I've stole this from Uncle Richie Matt up on the Cape. So, and he mentioned this. In fact, it was 9/11 was the day that Uncle Richie used this, and it's about capacity restoration. Our communities always had capacity, and due to past policies and practices and colonisation, some of that capacity has been undermined, and in some cases even totally removed. So we like to work on a strengths-based approach around capacity restoration and providing through care. The other critical thing is the rates of suicide in our peoples. In 2018, there were 169 Aboriginal people who died from suicide. which equates to a standardised death rate of 24.1 deaths per 100,000 persons. And in 2017, there were 165 suicide deaths, which was 24.2. It is the 5th leading cause of death for our peoples. There were 129 male and 40 female suicides in 2018. The sex ratio is 76.3% of male, 23.7% female in 2018, and this is the ABS data as at the 25th of September last year, based on the last census and National Coronial Information Service data. The median age for our people taking their own lives is 31.8 years of age for males, but even more tragically, 26 years of age for our women and girls. Some of their data, now this will be really hard to see and it's can be complex, but you can see here the standardised death rates for all states and territories for the 5-year periods 2009 to 2013 and then 2014 to 2018. And you can see that in all jurisdictions, bar the Northern Territory, that rate increased over that period. The other really critical thing, and this comes back to the intervention and prevention, is that intentional self-harm is one of the 10 leading causes of death for Aboriginal and Torres Strait Islander males and females. And it is the 2nd leading cause of death for our men, and it's the 7th leading cause for our women, as at 2018. You know, I can remember 10 or 15 years ago when our leading causes of death didn't have suicide in there, and we were talking about chronic disease. And it's sad to see that we've still got chronic disease, but sitting right up there in the top 10 now is taking your own life. The table on the screen is, again, from the ABS data, as I said. The data that's been reported to our service for this year is that we currently have a total of 87 suicides as at the 14th of September, and unfortunately, I hate to say it, we've had a couple more in that time. There's some good news there in that at this time last year and for the same period, 1 January to 14 September, there were 144 suicides, so it's a decrease of around 60. What is also quite sad is that the predominance of the people taking their own life are under 30. More than 50% of the suicides reported to us this year were for Aboriginal and Torres Strait Islander peoples aged under 30. Really sadly, we've had 5 children and young people under the age of 15 this year who've taken their own life, and the youngest was 9 years of age. Whilst the statistics are a little bit better this year, I say with caution, as there are different protocols in each jurisdiction about whether or not they notify our service. We are currently trying to reinstigate and refresh and revitalise MOUs that were in place previously. But as an example, in Victoria, they will not tell us about a suicide formally, a formal notification, unless the family has agreed to a referral for service. What we are trying to get these organisations such as coroners and police and others to do is advise us of a notification which is de-identified but does tell us the decedent age, gender, location and, if possible, method of death. And then if and when a family agrees to a referral to our service, then the referral contains the much more detailed information, including, family members' contact information, name of the decedent, and those other items. The other challenge with the data, which is why the ABS data is most often referred to, is that coroners are very loath to make a determination on suicide in certain circumstances, for instance, where there may have been drugs and alcohol involved, or it's a motor vehicle accident. We've had one recently where it was initially an MVA, then they thought it was a suicide, and then it went back to being an MVA after the police investigation. And that hampers the coroners wanting to inform us in case it turns out that it wasn't a suicide, but it may have been a homicide, or it may have been an accidental drug overdose. So that does cause challenges with live data. But on the surface at the moment, we are way better off this year than we were at the same time last year in terms of numbers, but still way, way too many people taking their own lives. So Thirrili started, and there's a bit of a mixed story here. So after ATSIS PEP, the suicide prevention evaluation, there was a proposal put forward by the Centre for Best Practice that there was a need for Indigenous-specific postvention services, and it needed to be national, but it needed to be delivered at the local and regional level. Now, we are all aware that is often the space in government where they say, well, we don't have enough money to do that gold star model, and they said they would do a national service that would deliver services locally and regionally. At that time, Jerry Georgatis and Adele Cox were working with Arnie Pat Dudgeon in the Centre for Best Practice, and over time it came that we would establish Thirrili and we would start delivering the service in negotiation with the National Indigenous Australians Agency. For me, there's two things there that we need to think about. One is that the primary funding for suicide prevention and postvention sits in the Commonwealth Department of Health and the states and territories' relevant mental health commissions and departments of health, and that money doesn't come to Thirrili. We are funded out of a very small bucket of money in the Indigenous Advancement Strategy by the National Indigenous Australians Agency. So the critical need for funding to be able to deliver this in a truly local and regional level is just not possible within the funding envelope that is held by NIAA. Nonetheless, NIAA are committed to a national postvention service. What the model looks like might be up for challenge, but they are committed to it and they continue to fund us. But there is a lot of work for us as Aboriginal and Torres Strait Islander peoples, as Thirrili and as other organisations, to keep promoting the need for the mainstream funding for suicide prevention to also be directed to an Indigenous-specific postvention service in much the same way as they fund standby on a national basis and other services. It was a staged approach to roll out, so it didn't go to all jurisdictions at once. And then over time, last year we were meant to expand into Victoria, Tasmania, New South Wales and the ACT. That had some hiccups and challenges along the way and stalled a little bit. But now we've done a fair amount of work. So in New South Wales, we've gone into a partnership with Wellways. They've got two amazing young Aboriginal men who do the work for the National Indigenous Postvention Service. And then in Victoria, we've just recruited a new advocate there. Tasmania is done by Victoria. We haven't had any notification of a death in Tasmania due to suicide in the last 2 years. And that, again, I stress that doesn't mean they haven't happened. It's just that we've not been notified. And the ACT is done by New South Wales as well. So we are in now every jurisdiction, including the Northern Territory. And Thirrili also delivers standby in the Northern Territory under contract to standby. And in South Australia, we deliver a program that was established, the Virtual Support Network, which was established as part of South Australian Government's response to COVID-19 and the mental health concerns, and we delivered a specific Aboriginal and Torres Strait Islander supports and services through that program. So we are continuing to get out and talk to other government bodies, other non-government organisations, Aboriginal community-controlled organisations, and other service providers to build our networks and to be able to ensure that we've got the networks necessary to provide wraparound supports to our clients when they need it most during their time of grief and loss and trauma. We have a fortnightly newsletter, and if you sign up for that, you'll find out all sorts of things about what's happening in the service, and we highlight various things at various times. So if you want to be in the newsletter, just sign up. You can go to the website and it'll give you the link to sign up to the newsletter, and you can see some of our previous, what are they called? Editions of our newsletter. Sorry, I had a mental block. So we support individuals and families affected by suicide and traumatic incidents causing death. In the past, we've had a sort of a mixed approach, and due primarily to relationships in communities that were in place for some of our staff, and we were often working with people who had attempted suicide and or self-harm attempts. Nonetheless, there is a significant bucket of funding in the suicide prevention space and suicide intervention space, and our funding is limited. So we've really come back to our core business, which is working with families and communities affected by a traumatic incident causing death, be that suicide or, as I said earlier, motor vehicle accident or other circumstances. We have a broad range of services. So we do the immediate bereavement support, and that might be just helping the family negotiate with the coroner and or police, or, you know, if the death occurred in the family home, helping them through either private leasing, if that's the situation, or through state departments of housing to find alternative housing to move them. If that's not a possibility, we'll work with those families for a smoking ceremony or other ceremonies that will help them feel they are able to maintain the house. We develop a care plan. That care plan talks about what are all the supports and services that the family and the advocate have worked together to identify. And that can be practical assistance. It might be, you know, that a nana now has 5 grandchildren coming to live with her and she needs a washing machine. Or it may be that there's a number of family coming together for sorry business and there's some financial support required for food. We do not provide any funding for funerals. It's prohibited expressly in our funding agreement. But the Emergency Response Fund is available for a maximum of up to $1,500 per family or per incident, and that can be fairly flexible so long as it's not a funeral cost. We have not done as well in the next area as we could have, and what we are really focusing on, which is building the capacity and restoring capacity to our communities and service providers to care for and respond to our families, and not just at a time of grief, loss and trauma, but to work through the whole gamut of social disadvantage that is experienced by that family. We want to make sure in our care plans that service providers that we've engaged with the family are keeping up their end of the bargain. We want to make sure with the client that if we referred them, for example, to social and emotional wellbeing support services, that they're finding that is helpful and that the person is who they need to see and that they are still going. And if there was a problem, identify another service who might be able to provide those supports. We focus on a time frame that is basically set by the family and when they are ready for various activities to occur. However, we also focus on really encouraging them to connect with services that will support their emotional and social wellbeing, as well as their cultural and physical wellbeing. And that care plan then becomes a through care plan where we talk about at what point through the case review, regular case reviews, and identifying how an individual and or family / community is travelling post the incident, about then what are the aims for transitioning Thirrili out of their lives, because they're able, with the supports, other supports that have now been put in place, to start to return to the activities and ways of working that they had before the incident. We are very much focused on a strengths-based approach. So we don't identify what is it the family can't do. We identify what is it that due to the trauma, the family is experiencing difficulty and needs support. We also identify what those family strengths are, and often that is just the family coming together. Often it is their cultural and spiritual well-being is very strong. Often the strengths might be that they are able to continue to look after children who may have lost a parent. So we do try and identify what are the strengths and work with the family to be able to identify their strengths and the way that they are coping in what is an absolutely critically traumatic situation. Rachel, I'm going to hand over to you.
No worries. Next slide. So in terms of Thirrili strategies around supporting staff development, we also look at, what needs to be working well when the person's impacted by that intense grief. Certainly making sure that it's very safe and supportive environment and that there's that trust and respect for our critical work. In terms of looking at those assessment needs and providing some of those referrals through to our services, because we can't be the be all and end all. And so when we talk about support for our staff development, not only do we recognise, the clinical supervision that we get through our local consultant, in terms of, if staff want that support, we've also got access to Corona Plus, which is an EAP program. There's also the access if they need a cultural healer for spiritual cleansing, as well as, debriefing sessions. And so Tanya's been fantastic, supporting a lot of the staff through the organisation in terms of making sure that clinical supervision's available. In terms of cultural healing, it just depends on what that looks like for that individual. And so that's just as critical as, talking through, looking at it through a debriefing session, because it's about, the spiritual side of things and what happens with, staff and their cultural beliefs. In terms of, the opportunity for staff to go through and do the debriefing, they've got the opportunity to go through that, as well as the opportunity to go through and look at external clinical supervision, if that's what the, the staff member is looking for. In terms of the work that we do, we're also engaging not only through with our key stakeholders, but services and agencies, to make sure that they are picking up some of their key responsibilities. And so, in terms of our clients and our staff working through directly, making sure that that guidance is based on the evidence that the client requires, not what we think as staff members working with our families, because as you heard Jacqueline say, each one of us has been, exposed to and have had that lived experience of what suicide can do when it comes knocking on your door. So it's really critical that it's about what our families need, and then how we can then make sure that those services that have that responsibility are working true to what they say they're going to do. Next slide. In terms of, is there a question, is there? Next.
That's fine, Rachel. We'll answer them at the end of your presentation.
No worries. Next slide there, Jacqueline. Is it moved over? Okay. To explore and discuss the links between postvention and intervention and what prevention is, suicide postvention is connected through bereavement support for the individuals, the families bereaved by suicide. Postvention can take many forms, but its primary purpose is to support those who have been affected by suicide to cope, reduce the risk of the suicidal behaviour and support healthy recovery. Postvention is also prevention when we're promoting healing and recovery, and this can in turn reduce the risk for suicide. And so for those that aren't familiar, you know, in terms of suicide itself, in terms of the postvention, it's a form of the prevention with our families who are directly impacted by suicide or other traumatic cases that has caused unexpected death, where families are highly vulnerable and are at the heightened risk of self-harming with the intent of causing death. The intervention that Thirrili and our service are constantly advocating for our families to be referred through mechanisms such as accessing counselling, mental health plans, and again, at the client's request, whether it's a traditional healer or cultural cleansing, you know, whether they're presenting at emergency services, making sure, and you'll be surprised how many of our clients go through and present at an A&D department, and they are released back into the community, and families are just beside themselves. So, you know, it's really important that knowing that you've got access to the community mental health triage. With young people, you know, we have CAMS Connect, the Child and Adolescent Mental Health Team. So it's knowing that there are other such tools out there. There have been instances where, you know, there's been a death, the deceased left behind, you know, young people, children, like many of our families. And so sometimes, you know, if they're not able to get into that counselling straight away or get into that doctor service straight away, some of those tools around our kids' helpline tools is quite another a tool that I definitely send through and make sure that families can access, because that's a 24-hour counselling, and it looks at the different ages and ranges, but it's also there for parents as well. So, you know, knowing what's out there is really quite critical. But if we can get our clients in to see doctors for that, you know, counselling and medical support, that's always quite critical. And then, you know, in some of the states and territories, we have a suicide aftercare program. So definitely very much important to know what's out there when we're talking about, you know, the postvention, the intervention, and definitely the prevention for the families that we're working through with. Next slide there, please. Okay, so we're further exploring and discussing the links between postvention and intervention. I guess suicide intervention is a direct effort to prevent a person from attempting to take their life to suicide. Did you get that one then? Next slide. Certainly, you know, when we're going through working with our families are always at the centrepiece of our work. And certainly that informs our through care planning that assists us to help transition our families, because not only when we talk about capacity restoration at a community level or at a service level, it's also at a community and individual level. And so, you know, suicide itself fragments a lot of families. It's, you know, it definitely breaks down a family unit. And so working through that capacity restoration within, you know, with our families and services, it's quite critical, because that transitioning, we need to know that, you know, they can then go forward and hold services that have a responsibility to be able to make sure that those supports are in place for them. And, you know, with that, it's equally a part of the services is, you know, if there are challenges between the engagement, and look, we know where we've worked with services, they have had challenges working with our families, and families just won't engage. So there's opportunities there where our advocates will come through and be that conduit, you know, to try and smooth things through. And if for whatever reason, you know, family don't want to engage because they're just not ready, it's about what they need in terms of their through care planning and how they then can support themselves through that family unit. But, you know, when we're looking at, I guess, that immediate family and what their needs are, it could be around social, financial, cultural, and emotional supports that impact them. And it's about how we then can support those family units in terms of the approach that we can go through and assist with. So what the next slide is, questions and time. Any questions?
So thank you, Rachel and Jacqueline, for your presentation. Like a deep thank you for sharing your expertise and also some of your personal journey and the journey of Thirrili. I think membership, I think it's really, really important for us to know what's out there at these critical times. So thank you. And I'd also like to encourage everyone to subscribe to the newsletter so that you're actually getting this information more frequently and more regularly. We do have questions, so I'll start off with the first question. There's one online right now. Can Thirrili suggest any good suicide prevention programs to deliver in schools?
I might hand to Rachel, but from my time, I used to head up Aboriginal education in Western Australia. And what we found worked really well was some of the work done by the social and emotional wellbeing teams, but also for our older young people, so our teens group. Aboriginal mental health first aid training is absolutely fabulous for our young people in that sort of 13 to 18 year age group. And that can be delivered by a range of people and organisations, and it's one that I know of. But Rach, do you know of other programs?
Yeah, in terms of a suicide prevention program, what's really important is, if the school are looking at delivering something like that and going through, depending on what state or territory you're in, definitely some of the local primary health networks, some of the local health networks that are around should be working in with the schools to look at what suits, how that impacts our young people, because not only do you have young people that are, attempting and self-harming and taking their life, there's also equally our older group of family members that are also equally doing that. But in terms of the suicide prevention programs, it's really important that the youth come together to see what it is they want to see around suicide prevention. And so from there, the schools themselves need to be able to bring in, like your primary health networks and some of those key stakeholders so that they can start developing. You've got a number of youth groups out there, like our Koori youth group, and, getting some of those speakers in to be able to look through and what that works like in terms of, our young people.
Thank you so much. There's another question here. What are some ways that our IAHA membership can support or be involved with Thirrili? So our membership online now, we've got Indigenous allied health professionals and non-Indigenous allied health professionals, but we've also invited in other members from other peak organisations. So everyone's working in health. But what ways can IAHA support Thirrili or be more engaged?
I think there's a number of ways. I think the first is at the really high strategic level, and we're talking about that sort of CEO to CEO around what is the strategic partnership we might develop. I think there's an amazing opportunity for Aboriginal health practitioners, be they psychologists or Aboriginal health workers or nurse practitioners or whatever, to think about maybe a secondment to Thirrili and to do some, a couple of months working with our teams and our families and our communities. And that builds not only the strength of our service with the quality of the professional expertise of those people, but it builds the expertise of those practitioners in working with suicide-affected families. The other opportunities are for us to potentially engage people as consultants on work we do, like pretty much we do with you, Tanya, as well as, on a personal level providing some of that clinical supervision, helping us with our programs such as our scholarship program. And I've just got to say, I don't know if you've seen this week's newsletter, Tanya, but we've got an article. We just ran our inaugural scholarship program. Tanya designed, delivered, developed, just about did everything, including make lunches. Thank heavens it was virtual. But, you know, the feedback from that has been absolutely amazing, and that's building a cohort and that will, you know, support our families and our communities and the work we do. It's a bit like Tracy Westerman's forever saying, you know, let's build an army. Well, we'd like to build an army of people that are available to support not only our people who are suffering grief, loss and trauma, but also our staff in the work we do and how we share our knowledge and experiences. So I think that's some of the key ways I could think of. So Nicole says, yes, let's get some information regarding secondment and consultants. Feel free, Nicole, to drop me an email at any time. Our emails are really easy. So it's our first name, dot with our initials. So I'm Jacqueline.m for Mary at thirrili.com.au. And Tanya will no doubt send out our details post this anyway. But I'm always happy to talk to people. We really want to spread the word about the critical nature of our services. Donna Murray, the CEO, had an amazing idea, and we put it out in the IHA newsletter that we're also willing to look at those people who would be on call. So if, you know, as I said, we've got a partnership with Wellways, for example, and they're based in Griffith and Wagga. But if we had a critical incident, I don't know, at Casino or Toomala, is there someone in that local area that could be our arms and legs on an hourly rate, or could we do part-time, or, you know, some innovative ways of employment opportunities so that we strengthen our workforce and we strengthen the knowledge and understanding about the criticality of an Aboriginal-led postvention service for Aboriginal and Torres Strait Islander families.
Thank you, Jacqueline. Thank you. I've just got some feedback here to share with you. People are saying, great presentation. Thank you for sharing this information with our membership. Yeah, thank you again. It is so important and you're doing such critical work. There was a question here that's quite important, particularly right now in the context we've just come through the pandemic and still going through the pandemic. And Jacqueline, you alluded to it before, like we're coming up into these peak times around Christmas, and you know there's increased people increasingly feeling lonely or disconnected from family if they're not able to get to family. So if families have someone they worry about that they might be thinking that they might be taking their life, what should they do?
Look, and I'll let Rach answer a bit too to this, but I think, you know, from my own personal experience, it is really critical that the family does try to engage that family member with some service or another, whether it's a Beyond Blue helpline, the social and emotional wellbeing team, but critically I think it's important to get to a GP, whether that's in an Aboriginal medical service or Aboriginal community controlled health organisation or mainstream, to get a mental health plan put in place, and so that there can be some counselling and supports provided. And Rach, you might want to add some more about this, about the work we actually do in families around talking about it and not shaming mental health, and, you know, saying we all suffer at some point in our lives. We have a low point, and so making it a space where people feel able to talk about their mental health and removing the shame of this issue, and being able to connect to services. There are a number of helplines that are often referred to, but critically, the primary health networks and GPs under Medicare are funded to develop mental health plans, and they are critical. And you may like to do that with a SUB worker at the AMS before you see a GP, but you can always reach out to a number of services.
And I think the other thing too is, you know, for our families that are living with loved ones who are attempting and talking about, you know, suicide, it definitely wears the family member down. And so, you know, it's really critical that they know that it's okay to call 000. to get that extra support in. You know, and sometimes our families, like Jacqueline said, are shame, but it's not about being shame, it's about trying to get those supports, because there are a large number of families that I know of that have indicated that they've constantly gone backwards and forwards through ADs, you know, mental health teams, and they are still not hitting the mark with their loved ones. And so there are systems failures happening, you know, across the place. And yes, we know we have a, you know, a mental health act here. We know that we have systems in place, but not everyone's perfect. But, you know, you've got to call 000 if you know that there's someone that's in immediate danger, because what's really important is if you get into a situation where you're placing yourself at risk, you know, then it cascades. So it's really important that you're always one looking after yourself, even though the loved ones are there. You know, and with all due respect, I didn't share earlier, but my son committed suicide at the age of 23. He left behind a 3-year-old son. So my grandson is now 12. And so, you know, working through that space, it is really traumatic for families. So it's okay to call 000.
I think the other really important thing here is we know that the mental health system in Australia is under-resourced and overburdened. And often people need the advocate for that service. So just anecdotally, my daughter niece came to live with me. She makes constant attempts on her life. Now, she was in the Austin Hospital in Melbourne on suicide watch. They literally put her in a taxi to the airport and flew her to Perth to live with me. And when I rang the Child and Adolescent Mental Health Service, they said, oh, we can see her in 6 months' time. And I said, you know, that's just not good enough. She's been on suicide watch for 3 weeks. Now, I was really lucky. I was a senior executive in the WA government. I rang the minister's office and spoke to the chief of staff and jumped up and down. And I had an appointment with the psych the next morning. But our families and communities don't always have that network or that understanding of how services work. So I always say that, you know, if it's not the immediate urgent situation of a 000 call, you know, ring people that you think might know something, ring the AMSs, speak to the SUE workers, ring a Lifeline or a Standby or one of those other services so that they can give you some other contacts relevant in your local area. But I'll tell you something else from my personal perspective. I don't care if 50 families a week ring us because they're worried about someone so that we can give them guidance on where to go for support. You know, my view is that we can't put hours and hours into supporting and developing case plans because we're not funded for that. But certainly we can, I think it's a good idea to put some resources on our website, Rach, about who people can contact if they're worried about a family member.
Absolutely.
Thank you. And thank you both for sharing your personal journeys. And we just wanted to share our thoughts and love and care towards you both. You're so passionate about this space, and you know, we're very privileged to have you both here tonight. We have another question from one of our members, long-serving members over in Western Australia. The Western Australia Mental Health Act 2014 has been amended to include the use of traditional healers and medicine and inclusion of family in the triage and assessment processes. Is this similar in other states and territories from your experience?
I can't answer that, Patty, definitely, because I'm not aware of all of the Mental Health Act requirements in each jurisdiction. But I can tell you that it does vary. I can tell you that as a family member, I've been told, you know, to go and sit over there. And I think it was Tanya I was telling the other day, you know, I had my girl, she'd been in an accident and emergency for 18 hours because they said there was no mental health bed. And I said, there's 2 Corey mental health beds at this particular hospital. Oh, but she's not Corey. And I'd been through this every time the kid had been in A&E, which was, you know, we were regular visitors, much to my distress. So they didn't like to include family, thought you didn't have value in some cases, and then in other cases they did it really well. I think that's still the case. I think that we have a lot of very well-meaning people in A&E and in GPs and other, you know, services, but they don't always understand the Aboriginal context. And I'm not sure that it's legislated to the extent it is in WA. I mean, I spent 15 years in WA as a senior exec in government, and they in WA, because I'm no longer there now, were actually ahead of the pack on a lot of the work they did around changing legislation relevant to Aboriginal peoples and Torres Strait Islanders. I do know that in Victoria, there is very strong commitment by the state government working with Aboriginal people and communities. There are a number of strong governance committees that have strong Aboriginal leadership at them, and in Victoria they have Ballot Marup, which is the Aboriginal Social and Emotional Wellbeing Framework, and that's connected to the Aboriginal Health and Wellbeing Strategy for the Department of Health and Human Services, which is Kurrin Kurrin Ballotjack. Both Ballot Marup and Kurrin Kurrin Ballotjack have strong Aboriginal-led governance groups to talk about how we deliver services. And Victoria, again, has been really proactive in some areas of legislative change, and they will have more legislative change after the Mental Health Royal Commission. But other jurisdictions are not as fast forward and forward-thinking as those two jurisdictions, but I can't be accurate about the specifics, I'm sorry.
And
Thank you.
definitely within South Australia, through the South Australian Health, also, advertising and acknowledging to the broader community around traditional healers going through and doing work in our hospital. So, yeah.
Thank you. We've got time for one last question. Given, I think you alluded to this again before, Jacqueline, when you were talking about how we talk about suicides in our communities from an Aboriginal perspective and also from, the service provider's perspective. Do you see the language changing? Do you see that stigma reducing as part of your work?
I think I do, and I alluded to this in another forum recently, that we are talking more about mental health. We're not being shamed. I think the challenge for our people still remains that the broader system talks about mental health, and for us it's about our social, emotional and cultural wellbeing. And sometimes the term mental health can be very damaging for our people based on past history and policy and practice relating to our peoples in various jurisdictions. We also talk about, and I know Rachel's just said this, so this is not a hard and fast thing, and it's so, and it's a personal thing. Suicide used to be a crime, and that's why people used to commit suicide, because they were committing a crime. We have a very strong movement in the broader mental health space right now to try and remove that view that it was somebody committing something, which is often a negative connotation. So we often talk about they suicided or they took their own life rather than they committed suicide. But we also have to recognise that we have many people in our communities, and that language has been around for a very long time. And, it's like all changes in language, and you see this in the disability space, they take time to come through. But the other really important thing, I think, is that we recognise that a number of religions have various components around suicidality and whether or not that is a mortal sin, etc. And so for some people there is that conflict between their cultural and religious beliefs. So I think if we talk about our social, emotional and cultural well-being and we use that phraseology more frequently, we will engage more people in the discussion. The biggest challenge is not keeping this hidden. It used to be that we never talked about mental health, and I can remember extended family member went to Greylands in WA for a very long time when we were kids, and they were in the institution, they were in the asylum, and we need to change that thinking in that language, and we need to be focused on how do we ensure we talk about our social, cultural and emotional well-being, and we talk about the fact that it's okay not to be okay. One of the things I've talked about recently is we never used to talk about family violence. It went on behind closed doors. Women were men's chattels. Women couldn't even go to police because it wasn't a crime for the man to do whatever he wanted. And then the legislation started changing, and now we know that we need to talk about it. And when we first started talking about family violence, when we first brought in things like apprehended violence orders or DVOs, you know, the range of different terminology, there was a perception that there was an increase in family violence. The perception wasn't necessarily an increase in family violence, but what it was now out in the open and it wasn't hidden anymore. And I think you can only address something when we're talking about it publicly. So for me, it's very important that we engage in the conversation, but we do it in a way that is culturally responsive. So we talk about it as our social, cultural and emotional well-being.
Thank you. And that's a beautiful way to end our professional development webinar this evening. We'd like to say a big thank you on behalf of our CEO, our IHR chair and all of our membership. And yeah, we're very privileged to have you. And we have this recorded, so this will be on our website, and we encourage everyone online to join the Thirrili website, or access the Thirrili website to subscribe to the newsletters. Charlie, do you have any other parting comments? If you can
send us the link for today, we'll probably not only put it on our website, but we'll put it in our next newsletter.
Absolutely, yes, I will do that. Thank you so much, ladies. It was just a fantastic webinar.
Thanks for having us.
Thank you.